another exciting webinar from the Dynamic Endoscopic Committee of Kasoga. And the topic for today is advancements in laparoscopy with special reference to the entryway, cystectomy, and on myomectomy. Let us start with invoking the blessings from the Almighty for the success of this webinar with a prayer. Mr. Arun?
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah.
So, to welcome one and all to this webinar, I invite Dr. Ravikant, who is the chairperson of the Endoscopic Committee of Kasoga, to deliver the welcome address. He is a professor at the KVG Medical College at Sulia, an avid laparoscopist with incomparable skills. Please, sir.
Good evening to all. Thank you, madam. Respected patron Dr. M.G. Hiramat sir, President Kasoga Dr. Vidya Tube madam, Secretary Dr. Rajeshri Palladi madam, and President-elect Dr. Bharati Rashekar madam, Advisor of the Endoscopy Committee Dr. Ramesh sir, Vidya Bhatt madam, resource persons of the today's webinar, and all the delegates who are joining for our today's webinar. It gives me immense pleasure to have a webinar on the endoscopy committee on enhancement in the laparoscopic skills, cystectomy, myomectomy, and abdominal entry technique. Our chief patron, Dr. M.G. Hiramat sir, who always encourages us to conduct scientific activities and gives all the support from all the side. I welcome Dr. M.G. Hiramat sir. Our president, Dr. Vidya Tubbe madam, who has continuously supported us in all the endoscopic activities. I welcome you, madam.
Thank you.
I welcome our secretary who meticulously helps us in all the activities of endoscopy committee. I welcome Dr. Rajeshri Palladi madam, secretary of endoscopy committee. I welcome our president-elect, Dr. Bharati Rashekar madam, who is helping, who also helps us to conduct a scientific activity. Welcome, madam.
Thank you, Dr. Ravikant sir.
I welcome our advisor of endoscopy committee, Dr. Ramesh sir, who is the main inspiration to conduct all the scientific activities like this. Welcome you, sir. I welcome our one more advisor who continuously helping us to conduct all the activities and meticulously helped us to conduct this event, even choosing the topic and choosing the right speaker for this event. I welcome our master advisor, Dr. Vidya Bhatt madam. Welcome you, madam. I welcome our today's resource persons, Dr. Jaiprakash Patil, Dr. Sonia Batra, Dr. Santosh Rathod, and chairperson of today's event, Dr. Prabha Desai, and today's MC conducted by Dr. Prema Dikuna madam, and all the delegates who are joining us. I welcome one and all. Thank you, madam.
And thank you, Dr. Ravikant. That was truly welcoming. So, though Dr. M.G. Hiramat is not here, but I feel that we need to give a recognition. So, he's our chief patron of Kasoga and had been past president of Foxy. We really miss his words. We have, however, other luminaries here with us who are our chief guests, and I would like to invite them to give, because no webinar, they would give us advice on how to continue with the scientific sessions and how to run our committees. I first invite our president of Kasoga, Dr. Vidya Tobi from Vijapur. She's the president, head of department there, and she has done a lot of work at Foxy Level 2. Please, madam, with all that experience, give us a few.
Yeah. Thank you, Dr. Prema, and really I must congratulate Dr. Ravikant. He
Yes.
has done magnanimous work as an endoscopy committee chair, and all his members, not only him, but all his members of endoscopy committee, they are very, very active. Few of them, they are right in Bijapur, of course. Dr. Santosh Rathod, who is a speaker, he is a young, dynamic laparoscopic surgeon of Bijapur. And of course, he has chosen the most bright and always academic people, always in his webinars. And our flag is flying high because the advisory for this endoscopy committee is none other than Dr. Ramesh as well as Dr. Vidya Bhatt, who has recently won the election, so that we will get many programs at the national level also. And today's topics are very nice. That is advancement of laparoscopy, which is excelling in cystectomy, myomectomy, and safe abdominal entry. So always we talk of safety first, and we know that how much medical legal problems are arising. And what is a great thing is we listen to the experts. So over to the very nice and very, I must say that we will see some of the videos and which the upcoming laparoscopic surgeon will definitely would like to see them. So Dr. Sonia Batra, Dr. Jai Prakash Patil, Dr. Santosh Rathod, and chairperson, especially I'm very proud of Dr. Prabha Desai from Gadag. She has done wonderful work in Gadag, and many times she will put her work across the WhatsApp university. So we learn from her also many things, our students. So over to Dr. Ravikant and his team for conduct of the webinar. Thank you very much for the invitation. And myself and Dr. Bharti, we are going for the election. Dr. Bharti is contesting for perinatology chairperson, and I will be for South Zone Vice President this time. So I always expect the wholehearted support from all the societies of Karnataka. So I make an appeal here to support us. Thank you very much.
Thank you, Dr. Vidya Tobi. You have always excelled. So there is, you can be
Yes.
sure of our votes with you. You have shown
Yes.
we don't have to even ask. It is yours for us to give. This.
Yeah, thank you very
And
much.
thank
Thank
you
you.
for your support as always. And you always
Yeah.
attend our the
Yes.
webinars and talk
Yeah,
to us.
looking forward
That
to the
itself
great
is-
webinar today.
Yeah,
Great
that-
webinar.
yeah,
Congratulations. Thank you.
Yeah. So I would like to welcome our next chief guest, and I would like a few words from Dr. Bharati Rajshekhar. She is the president-elect, and soon in the next month will be taking over the Kasoga mantle. And she's from Hassan. She has a lot of interest in, especially with adolescent gynecology, non-communicable diseases, screening and preventive oncology, and a lot of other programs. Please, madam, could you speak to us?
Thank you, Dr. Prema, for those warmly welcoming words of introduction. And at the outset, I would like to thank the chairperson of the Endoscopy Kasoga Endoscopy Committee, Dr. Ravikant, and the entire team for having me here on this evening. And as endorsed by our president, Dr. Vidya Topi, endoscopy has made rapid progress in Karnataka, and we have got young doyens who have done wonderful endoscopic surgery. For example, watching Dr. Jaiprakash Patil's videos and his simple explanation is such a delight, and it inspires us, our little old timers who did take up endoscopy quite late in life because we didn't have it in our postgraduate days, and it has indeed inspired us to give the patient the maximum benefit by doing the minimum harm, especially in simple surgeries. I remember almost 25 years ago, Dr. B. Ramesh was the one who was going all around Karnataka in his car trying to make us take up minimal access surgery. And that is how we were all mentored and we were taught, and then we have definitely taken up endoscopic surgery in our own way. But nowadays, thanks to the digital media, the younger faculty fraternity have a wonderful team of faculty members among our own endoscopic team of Kasoga who are ever ready to teach them to master the skills of endoscopy. And as Dr. Vidya said, we have a lineup of wonderful topics today. The basics like how to avoid making mistakes and safe entry ports, how to master the art of suturing. So these are the topics I think first, these are the art and skill which we first need to master, and so that we can have safe practices. So I thank the endoscopy team for giving us the opportunity to be here. And again, on behalf of Dr. Vidya Tobi and myself, I know Kasoga is always with us, but however, please do not forget to vote. What happens is many people in their busy practice, they do forget to vote. Nowadays, it is very easy because it's a digital platform, and the voting will be, of course, time is there for in August. And again, on this platform, I would like to invite all of you for the Yuva Kasoga conference, which will be held in Manipal on April 13th and 14th. We have an endoscopy workshop over there the same day. And of course, all the endoscopy committee members will also be there. We have this, and it is an opportunity for all the younger residents and the postgraduates and the people who are much younger who can take benefit of this endoscopy workshop, which will be conducted in Manipal. And all of us are familiar with the expertise of Manipal Institute. And at the same occasion, I will be taking charge from Dr. Vidya Tobi, who will persistently be behind me, guiding me in my new endeavor as the president of Karnataka State OG Association. So I extend a personal invitation to each one of you to kindly be there so that we can show our strength and move forwards for the betterment of women's health. Thank you very much.
Thank you, Dr. Bharti Rajshekhar. It is having people like this who can remember from where it started, endoscopy, as you mentioned, Rajshekhar. It is important we know the history of this endoscopy and its growth in Karnataka. That's important. The youngsters will understand and where all, hence they will take it into the future. We also wish you best in your coming elections, and you can be assured of our support like this. Yeah. And to continue with this thing, we are unfortunate at the present moment of time, but we are hoping Dr. Ramesh, Dr. Vidya Bhatt, and Dr. Rajeshri Palladi, with our advisors and chief guests, would join us. But I think, Dr. Ravikant, we can move directly to the scientific session.
Yes,
and
madam.
invite the others as they join us for their words. Okay, so welcome all to the scientific session. We are in good time. Please make good use of it. We have wonderful speakers. And so with this, I call upon Dr. Prabha Desai. She's the chairperson. I don't see her yet on the list, but I would like to introduce her and she can join us whenever she is free. She's there? Okay. So Dr. Prabha Desai is from Gadag. She's one of the younger, she's our committee member, but she's one of those youngsters, but seriously into endoscopy, and she likes to take it statewide, and you will see her in all as a operating faculty or advisor, or she gives talks on endoscopy with us. We are lucky to have her. And but we will be now going to our first talk of the day. This is from the young and energetic Dr. Sonia Batra. She's from Shimoga, and she's our honorary secretary of this endoscopic committee. And she's also the honorary secretary for the OG Society at Shimoga. She's a member endoscopic committee at the Foxy level, and she's a proactive member of the public awareness committee at Foxy. She's got a lot of credits to her, but I think in your talk, we will be able to know more about you. She will be talking to us about the from controversies to clarity. She will be talking about mastering the safe entry techniques in laparoscopy. Over to you, Dr. Sonia.
Thank you so much, ma'am, for your kind words. First of all, I would like to thank all the seniors, including the guest of honor, the chief guest, the chief advisors of Kasoga Endoscopy Committee, and the chairperson Kasoga Endoscopy Committee for giving me chance to talk on this platform. Thank you so much. Without wasting time, I'll just start the screen sharing and just let me know if it is visible. Is my screen visible to all?
There is a screen. Yeah, yes, it's visible,
ma'am.
Dr. Sonia. Go ahead.
Yes. Thank you. And my audible clearly?
Yes, very clear.
Okay, thank you so much. So I'll just start with the topic. Laparoscopic injuries frequently occur during the blind insertion of needles, trocars, and cannula through the abdominal wall, and hence the period of greatest risk is from the start of the procedure until visualization within the peritoneal cavity has been established. So that is why it's very important to have the safe entry techniques in laparoscopy, controversies to clarity topic, because whenever we are safe at the entry point, then only we can have the entire surgery nicely. So approximately 50% of all the complications during laparoscopy are entry related. 1 in 4 is not even diagnosed during the operation. Now, these entry-related complications can be divided into two types, like minor, like for example, epigastric vessel perforation.
Yeah.
Hello.
You go
Or-
ahead. There's some disturbances.
Yes.
Go ahead.
Okay. Or it can be major in the form of vascular complications or bowel perforations. Now, how to diminish these entry-related complications? It depends on the surgeon's experience, as we all know. Understanding of the relevant anatomy, proper use of the surgical instruments, choice of optimal surgical technique, and ability to detect and manage complications is very much important before starting the procedure. Now, the surgeon should follow the safe abdominal entry guidelines for position of the patient, placement of the varus needle, pneumoperitoneum, primary trocar insertion, accessory trocars, and identification of high-risk patients. Now, my entire lecture will be revolving along all these points, and I'll be covering all the major guidelines like Cochrane and Green Top guidelines and Society of Gynecologists of Canada guidelines. So let's start it. Now, positioning of the patient is very important. Dorsal lithotomy position with lowered legs. In the beginning, many of the beginners are confused, like it is always said head low is the position, but actually not. Before starting, before putting the first trocar, the operating table always has to be horizontal, not in the Trendelenburg tilt, because if at all it's a Trendelenburg tilt, then as we can see over here, Trendelenburg tilt makes the blood vessels prone for complications over here, because when it is horizontal, the varus needle, if it is pointed towards the pelvis, there are very less chances of complications. But when we tilt the table, the blood vessels are actually prone to have prone to get injured over here because of the proximity. So that is why this Trendelenburg position has to be avoided and the table has to be horizontal. Apart from that, the abdomen has to be palpated to check for any masses and for the position of aorta before insertion of the varus needle or trocar. Now, first we'll be talking about varus needle or closed laparoscopic entry technique. Now, this is according to the things over here are according to the Green Top guidelines number 49, May 2008, and the things in violet are according to the SOGC clinical practice guidelines. Okay, so here in this case, how should the closed laparoscopic entry technique be performed? So, what we see over here is, in most circumstances, it has to be the primary incision for laparoscopy should be vertical from the base of the umbilicus, and the varus needle should be sharp with this good and tested spring action. It has to be right angle to the skin. As you can see over here, the needle is always has to be right angle to the skin, two audible clicks, as we all know, and excessive lateral movement of the needle should be avoided, as this may convert a small needle point injury in the bowel of the vessel, in the wall of the bowel or vessel, into a more complex tear. Now, the varus needle can be inserted intraperitoneally at umbilicus or left upper quadrant. It depends on our preference. But left upper quadrant placement is associated with fewer attempts and fewer conversions to alternative sites. Initial variance interperitoneal pressure of less than 10 mm Hg is the most reliable indicator of correct varus needle placement. Now, the weight of the patient decides the direction of the varus needle with the horizontal. With the skin, the varus needle always has to be perpendicular, but with the horizontal, during insertion, the varus needle's angles with the horizontal or with the table, it has to be less than in between and 45 degrees if the weight of the patient is less than 75 kgs. If the weight of the patient is less than 75 kgs, it has to be here at the angle of 45 degrees so that it is towards the pelvis and not injure any of the major blood vessels or the viscera. There are less chances of injury here. When the weight of the patient is 75 to 90 kgs, then it has to be in between 45 to 90 degrees so that it is pointed particularly in the pelvis, and again you are not even traversing in the fat or nor even to the blood vessels over here. Now here, coming from here up till here, that is by the increase of the weight, as we see, the distance between the indented umbilicus and the viscera also gets increased because of the increasing fat. So that is why when we go to the weight of greater than 90 kgs patient, then it has to be correct 90 degree, perpendicularly correct 90 degree, so that we are actually there inside the abdominal cavity and not traversing in the fat over here. Now, what intra-abdominal pressure should be achieved to safely insert the primary trocar? Here, according to the Green Top guidelines, 20 to 25 mg of pressure should be used for gas insufflation before inserting the primary trocar. Now, why? Because if a constant force of 3 kg is applied to the abdominal wall at the level of the umbilicus, then if the pressure is 25 mmHg, the distance between the indented umbilicus and the viscera is around 5 to 6 centimeters. But with the intra-abdominal pressure of 10 mmHg, the distance between the indented umbilicus and the viscera is around 0.6 centimeters, which is very less. So there are chances of some injuries. So that is why it is suggested that all gynecologists should consider using the pressure technique in insufflating the abdomen to 20 to 25 mmHg before inserting the primary trocar. Now, where should the primary trocar be inserted? It has to be at the thinnest part of the abdominal wall. Stop the trocar immediately as soon as it is inside the abdominal cavity. And as soon as we enter, the laparoscope has to be rotated through 360 degrees to check out visually for any adherent bowel or any other thing which is there. So just for a check, we should rotate the scope through 360 degrees. Then, if there is concern that the bowel may be adherent under the umbilicus, the primary trocar site should be visualized from a secondary port site, preferably with a 5 mm laparoscope. Again, on completion of the procedure, the laparoscope should be used to check that there has not been a through and through injury of the bowel, because in many of the cases, like through and through, we have completed the entire surgery, and then we are not able to understand like it has been a through and through injury through the bowel, and so we should always check it visually before removal. Now I'll be talking about the Hassan's technique or the open entry technique. How should the open entry technique is performed? We give the incision at the base of the umbilicus, and then as soon as we reach the sheath, we give a stay suture. We take lateral stay sutures over there. Now, and then after we visualize the bowel or omentum, we insert the blunt tip cannula. Now, the Hassan's technique allows the insertion of the blunt-ended trocar under direct vision. This is the advantage. And secondly, these lateral stay sutures are very advantageous. They have two advantages. One is that they can be tightened on the cannula so that it becomes an air seal tight. And at the end, many of us encounter problem in taking the sheath. So when these lateral stay sutures are actually tight, then it decreases the risk of herniation. Open entry is neither superior nor inferior to other entry techniques. Open entry has a lower incidence of vascular injuries, but a potentially higher incidence of bowel injury according to SOGC clinical practice guidelines. Just a moment. Now, direct trocar insertion. Direct trocar insertion is an acceptable alternative procedure, but why it was used is many times people felt difficulty in grasping the abdominal wall, which was already distended by the pneumoperitoneum created by the varus needle. So to overcome that, the technique direct trocar insertion was also developed. It is the most rapid method of entry, but direct trocar insertion is associated with fewer insufflation complications and pain entries. However, there is insufficient evidence to conclude that direct insertion is associated with fewer major complications according to SOGC guidelines. sorry. Alternative sites for primary trocar or varus needle insertion, as we all know, it's the Palmer's point. Palmer's point is the most preferred site. It is at the mid-clavicular line, 3 finger widths, off the midline, 3 finger widths below the left costal margin, and the prerequisites are gastric emptying has to be there, no history of splenic or gastric surgery, no hepatosplenomegaly or gastric masses. Now, what specific measures are required for laparoscopic surgery in the obese women? According to the guidelines, it is recommended if the patient is obese, open technique or entry at the Palmer's point are recommended. If the varus needle approach is used, as we already discussed, it has to be there perpendicular, 90-degree, at the base of the umbilicus. Because if the needle is inserted vertically, the mean distance from the lower margin of the umbilicus to the peritoneum is 6 centimeter. This allows placement of even a standard length needle, even in extremely obese women. Insertion at other angles like 45 degrees, even from within the umbilicus, means that the needle has to traverse the long distance, like 11 to 14 centimeters of distance might be there, which is too long for a standard varus needle to traverse. What about thin women? Yes, thin women also, according to the guidelines, Hassan's technique or insertion at Palmer's point is recommended for beginners because aorta may lie even less than 2.5 centimeter below the skin in these skinny thin women. What about the secondary ports? Secondary ports have to be inserted in a direct vision perpendicular to the skin. The inferior epigastric vessels should be visualized laparoscopically to ensure the entry point is always away from the vessels. Once the tip of the trocar has pierced the peritoneum, it should be angled towards the anterior pelvis, and secondary ports must be removed under direct vision always. Now, what about when the laparoscopic landmarks are not available? When the laparoscopic landmarks are not available, secondary trocar should be placed 5 centimeters superior to the pubic symphysis and 8 centimeters lateral to midline to avoid injury to the vessels of the anterior abdominal wall. Now, these are the new system as we can see, but this is the disposable visual entry system and this is the VisiPort. But according to the guidelines, single-use push-through optical trocars are not superior to blind methods of inserting trocars and do not avoid visceral or vascular injury. Reusable visual entry cannulas have no sharp or pointed trocar, minimize port wound size, and reduce insertional force. As a consequence, they may be safer than trocars according to SOGC clinical practice guidelines. Now, visual entry systems, what are the advantages? They have a clear optical entry, minimize the entry wound, reduce the insertion force, no tissue cutting but dilatation, and integrity of the facial layers is maintained. Now, direct varus needle with optic catheter is also available, as we can see over here. Now, this is an interesting system, Versa step system. Now, in this, there is a varus needle with the nylon stretchable sheath over disposable varus needle. So what happens is once inserted, the sheath is dilated by inserting the trocar with the dilator in place, and then the sheath over here spreads outside, that is radiates outside, and without cutting, cutting entry blade, it decreasing the trocar side bleed and the potential for an intra-abdominal injury is also decreased. But according to the guidelines, the blunt tip of the radially expanding trocars may provide protection from injuries, but the force required for entry is significantly greater than for the disposable trocars. Then these are disposable shielded trocars. Shielded trocars do not result in fewer visceral or vascular injuries during laparoscopic access. Now, management of abdominal wall access with probable intraperitoneal adhesions. Of course, we all know Palmer's point can be used. We all know open laparoscopic technique can be used. It can be like direct optic catheters, optic ways can be used. Then the other thing which I encountered is like periumbilical ultrasound guided saline infusion technique. Now, this technique involves the injection of a small amount of sterile saline into the area of laparoscopic entry to detect subumbilical adhesions perioperatively. Now, Cochrane, what Cochrane says, if we compare open entry versus closed entry, evidence was insufficient to show whether there were differences in the complications. Then direct trocar versus a varus needle, definitely direct trocar has revealed a reduction in the risk of failed entry with the use of direct trocar entry. However, there is no difference in the complications. Direct vision entry and varus needle entry, if we compare, evidence was insufficient. So no clear consensus has been reached so as to which is the optimal method of laparoscopic entry into the peritoneal cavity. It depends on the skills of the surgeon and the comfort and experience of the surgeon. So conclusions, I conclude with the surgeon's skill and knowledge is very important for minimizing entry-related complications. Proper patient positioning is the key. Understand anatomical landmarks and relations follow abdominal entry guidelines, and beware of high-risk patients. Use of proper surgical instruments and alternative strategies is the key to success. Thank you.
Thank you, Dr. Sonia. That was a crisp presentation of what was safe as we do the entry into the abdomen. The session is open for questions, Dr. Ravikant, or it's for opinions or questions, or we go to the
Keep it in the end, madam. We'll take the
we'll
question
keep it at the end, or if there are questions in the chat box. Okay. If you can ask for you can ask your query, write in your queries in the chat box, or you can open up the mic later and talk. Okay. So thank you so much, Sonia. Yeah.
Thank you. Thanks a lot for that.
Okay, so we are going on to the next speaker, another person that we have been waiting to hear from. He is Dr. Jayaprakash Patil, and he's from Raichur, and he's got the briefest of CVs. He's a laparoscopist and pelvic surgeon, and he has been in the past. He was the past chairperson of this endoscopy committee of Kasoga from 20 to 22. He has been operating faculty in several state and national conferences. His area of interest is endometriosis and fertility enhancing surgeries. Dr. Jayaprakash Patil is but well known for his videos in all the endoscopy groups, and they are brilliant, epic videos you put, sir. Thank you so much. We all learn from it. Learn a lot from your surgeries. We welcome you to this session. Your session is on laparoscopic myomectomies. You will be talking about the mastering the incision and stitching techniques. Welcome. The stage is yours. We also welcome Dr. Prabha Desai, the chairperson for the scientific session. You were introduced, ma'am, but we now welcome you. She's there. You look like you're in San Francisco. Your mic is off. Dr. Prabha, you're muted. Can somebody get across to her that we can only see her now?
Hello.
Yeah.
Hello. Do you hear me?
Yeah. Now we are.
Hello. No, sorry. I stuck in OT, so I joined little late. But I heard little talk about Sonia's port entry. It was really excellent.
Yeah. Dr.
Thank you.
Jayaprakash, it's yours. It's yours.
Yeah.
It's yours.
Yeah. Elrigu namaskara. First of all, I want to thank Ravikant sir, Tobi madam, Bharati ma'am, and all the team of Kasoga. It's a wonderful team for this wonderful opportunity. There is a small technical glitch. For some reason, my video is not getting saved. So I'll be playing this video from the iMovies itself. Hope it is okay.
Sure.
So instead of, do you see this screen, ma'am?
Yes. You're audible, clear, and your screen is visible. And it's moving. Though.
So instead of putting out the slides and they giving you a lot of theory, what I thought was that I'll be showing you the video. Okay, I have prepared a video of 20 minutes, so I'll be finishing my talk while you watch the video.
Okay.
So before getting into myomectomy, the planning plays a greatest role. You all would agree with me, I'm sure. And I am blessed to have my colleague Raju Gireddy, who gives me such beautiful images so that I can plan my entry, I can plan my incision, and I can plan my suturing, and how many myomas to remove and where all they are situated. So it's very important to have a mapping. If you are good with your transvaginal scans, it's great, go ahead. If you are not very comfortable, you may get somebody to do, or you may even take an MRI in a situation where there are multiple fibroids. Okay. Now, whether you go with a vertical incision, horizontal incision, it depends on the location and also your suturing style. See, I being a center port surgeon, that is the suprapubic surgeon. So I always take incision on the myoma vertically. Okay, what it makes is, it makes my hands move very comfortably and put the sutures in a transverse direction. If you are a ipsilateral surgeon, your preference would be to take below upward sutures, and you have to take a transverse incisions. Okay, first I'll be showing my videos, and then in the last I have just included Vivek Salunke sir's video to show what is ipsilateral suture is like, and I have taken his permissions to show his videos. Now look at here, we have multiple myomas in this patient, and what you do, whether you take out and dig out from same incision or you give separate incision, depends on how proximal or how far the other fibroid is which you are going to tackle. Now there on the other side, you saw that I could not have taken both the myomas in one go, so I have taken a separate incision. Now it so happens that if you are good with your myoma mapping, you can plan in such a way that you end up with one incision taking out 2, 3, sometimes even 4 myomas. Okay. Now, recently I was talking to my junior colleague and I just asked, do you know who is Victor Boni? And to my dismay and to my disappointment, she did not know. Okay. Now we should all remember Dr. Victor Boni, who has laid out the principles of myomectomy. Remember, most of the principles of myomectomy holds good even today, what Victor Boni has described some 40, 50, 60 years ago. Only thing is now we are doing laparoscopically. Okay. Now he explained about, digging out the myomas and reducing the number of incisions, which we are trying to follow in laparoscopy. He made something called as a hood technique, where you reduce the exposure of the suture material and raw area so that the adhesions are less. We are trying to replicate that by the base wall sutures and other techniques. So all these things are actually laid down by Dr. Victor Boni. Okay. Now, another thing, what is very important is, no matter whether you take a transverse incision or a vertical incision, what is important is that you reduce at the end of the suturing, you should have minimum dead space. Okay, because the moment there is a dead space, there is a hematoma formation. The moment there is a hematoma formation, there is a fibrotic scar tissue which heals poorly, and you increase the risk of uterine rupture in her subsequent pregnancy. Now here you can see I am digging out the other fibroids from the incision made on the fundus. The other two sutures have been, other two myomas have been taken out with a separate incision, where in this fibroid happily coming out through the same incision. So you have to have a mapping, as I said before, and plan your incisions and take it out. Now remember, I want to impress upon another factor, which I have the luxury. I do take ultrasound into my OT while doing a myomectomy for multiple fibroids, because it is very easy to get lost. Okay, you don't know how many fibroids you may be leaving behind. You don't know whether you're taken out all the fibroids. Sometimes there will be a bouncer, you will have additional fibroids. So what we do is, once we are done what we think has done with the taking out all the myomas, we do put normal saline into the pelvis and then do a transvaginal scan. Okay, I'll come back to that. Now here you can see that this is a very large myoma bed. Now you have to put it in 2 or 3 layers, and some people don't want to take names. They advocate taking out all the myometrium which they don't want to approximate. What basically happens is, see, myometrium can only have a hyperplasia. The number of myofibrils is constant. So if you take out a part of myometrium, you are actually creating a defective scar, a poorly healed scar. So you have to do a technique where you don't take out the myometrium, but do a proper approximation so that there is a minimal dead space. Now, as you can see, I've taken one layer approximating the myoma bed, and the second layer, what I do is a overlap technique. Okay. See, this overlap technique, we have learned it for adenomyomectomy, but not only for adenomyomectomy, it is helpful even for myomectomy as well, especially when they are very large, something like 8 centimeter, 10 centimeter, 12 centimeters. Another thing I want to impress upon is the use of barbed sutures has made our life so easy. Okay. Not just because it is faster, not just because it is easier, but the tension across the suture line is uniform, whether you're taking a first suture or whether you're taking the last suture, the tension is equal, and you can give a good traction so that the tissue approximates beautifully, and you can expect a very minimal or nearly zero dead space. Okay. Now this here I am doing the classical the baseball suturing, not this overlap technique. I'm very sorry for that. This is the baseball technique where you take the bites inside out, inside out, inside out, inside out till you finish. So basically what it does is it pulls over the subsequent tissue from the next suture so that the exposure of the suture material is very minimum, as you can see. And the suturing, the approximation is great, and at the same time you have very minimal exposure. Now listen, this came as a surprise. This was reported as a ovarian tumor. Okay. When I went in, this was a very large fibroid, but it was nearly pedunculated. Now imagine whether I am a ipsilateral surgeon or a suprapubic surgeon or a contralateral surgeon, my incision will be same. Okay. Here I am taking out the myoma, leaving sufficient tissue so that I can do a proper suturing. Okay. Now, after this is done, now whether you want to suture it transversely or vertically will purely depend on your style of suturing. So it doesn't really matter. And I did look up the literature, and interestingly, in one of the papers, they said that transverse incision give lesser bleeding. I found it little amusing because the type of incision hardly matters as the amount of bleeding. I don't know about that, but many other studies did contradict and told us the type of incision and type of suturing entirely depends on the location, the size, and the operator skill. That is basically what type of style you have. Now here, as you can see, I completed the vertical suturing. Now remember, since it is a posterior fibroid, I have to go reverse suturing. Okay, I cannot put the suturing like this. So it is always reverse. Here I am manipulating the uterus with a vaginal manipulator, and you have to be good with your reverse suturing, especially posterior fibroids. I don't know what is the reason. I always get posterior fibroids, and it is not very easy to suture posterior fibroids. But then, as you keep doing many cases, you eventually find out which is the best way. Now, this is another case which I said I'll be showing you the overlapping technique. Now, this is a huge fibroid, about 10 centimeters big. And one thing, remember, especially when you have a big fibroids, you have to cut more to decide the good plane. Okay, how to get into a good plane? First, you cut more. Even if you have entered the myoma, come back and identify. Because what happens is, if you leave the myometrial tissue onto the fibroid, the separation becomes all the more difficult. As in this case, as you can see, there is some amount of myometrium onto the fibroid, so I was struggling to enucleate it. If you're in a good plane, it just comes out like a butter. Okay. Now, this is an overlap technique where one flap of the fibroid, the myometrium goes below and obliterates the dead space created, and the other flap will come over the first flap and forms a kind of 3-layered suture. What it does is it effectively decreases the dead space, number one. Number two, it reinforces the myometrial tissue to give good strength and a good scar. Okay. Now, this technique is maybe little intimidating for a beginner, but if you watch it again and again, it's very easy. You just take a bite of one flap, go at the base of the other flap, come back. You may take 1 or 2 bites into the base of the myoma bed so that you don't leave any dead space. Then again, come to the other side, and then you keep doing this till you are completing the whole process. Okay. Now I have completed the first layer, and then I'll be going to obliterate and overlap the another flap. Okay, like this. Okay. Now, you may ask me, some people prefer to do with Vicryl. Yes, you can do with Vicryl. The prerequisites for suturing with Vicryl is you have to be extremely good with your suturing skills and knotting techniques. Number one, because you can't afford to have a loose knots where you may leave a lot of dead space. Number one. Number two, however good you may be, suturing with Vicryl does take more time. So what happens? Your vasopressin does wear off in 20 minutes, and after that you may have a bleeding, so which is kind of nonsense. So V-Lock has made our barbed sutures has made our life very easy. Not endorsing any brand here. So this is how triple flap has come. You can see that there is a huge mass, there was a huge defect, but at the end I could suture very well. Now this is video by Dr. Vivek Salanke sir. So this is a very interesting location. This is at the isthmic region. Now see there, he is an ipsilateral surgeon. Now how he plans his incision? He takes a kind of a diagonal incision so that he digs out into the myoma. Sorry for the poor quality of video because I had to download it from YouTube. So what he does is he takes a diagonal incision so that he can suture from below upwards, and because he is an ipsilateral surgeon, he cannot do above downwards incision. He always has to do a below upwards suturing. So he takes a transverse and transverse diagonal incision. So it is all about planning how you like to operate. What is your preferred method of suturing? And many Cochrane studies, many other studies have told us that if you do a proper approximation and don't leave any dead tissue, the healing is equal with any style of suturing. Okay, now you see here, see he is doing a reverse suturing. That is the below upwards because he is an ipsilateral surgeon. Okay, this is what I wanted to show. So it depends entirely on your skill sets at the end of the day. Okay. So, and another thing, after any type of myoma, whether you have opened the endometrium, whether you have not opened the endometrium, actually there is hardly any great evidence to show that you should not open the endometrium. And if you do open endometrium, the scar will be weak. It is nothing like that. And actually, some people deliberately open the endometrium so that, the myoma bed drains out the collection. And then they believe that it is, but you don't include them in the suture. Now, again, look here, it's a fundal fibroid. He's taking out through transverse incision. Okay. And another thing, whether to use the energy source or not is purely personal. Some people don't prefer to use energy source, but I always use, I'm sorry, cutting bipolar current so that, it is faster, number one, and it does cause hemostasis then and there itself. Okay. So I am okay with it, and I've been doing these procedures for very many years and then without any problems. Okay. So same thing here. One disadvantage which I consider with the transverse incision is, especially if it is posterior, you have to be extremely careful not to outrun the myometrium and enter into the broad ligament. Okay. Whereas in vertical, there is no such risk, where you stay onto the body of the uterus nevertheless. Okay. But then most of the time, your incision is obviously smaller than the body of the uterus, because uterus would have expanded. But what is important is you should not do any conjugacy as far as the taking incision is concerned, because your incision has to be very adequate and pull out the myoma completely from the bed with that adequate incision. Okay. Whether you have taken a 3 centimeter incision and trying to pull it out, or whether you've taken a big incision to pull it out, it hardly matters. It has to be adequate. Obviously, no need to take a very big incision, but then it has to be adequate. That's the whole thing. Again, you see the style of suturing. This is how you do. See, the vlog comes in 30 centimeter and 45 centimeters. I suggest for a beginner to use a 30 centimeter, because you don't get overwhelmed with large length, and then you get confused. Of course, Salakya sir is a master, so he has taken a long barbed suture. But then my suggestion would be to take a 30 centimeter to begin with. Once you master that, you may go for 45 or 60 centimeter length vlog also. Okay. So this is how you close. So in conclusion, I just want to tell that depending on the size, depending on the location, depending on your style of surgery, you need to plan your incision onto the myoma. Number one, have a good mapping, and suturing is always how to take care of the dead tissue and good approximation. Okay. So that will end the video effectively, and I am open to take any questions.
Thank you, Dr. Patil. That was a brilliant presentation. You used so many, from hand diagrams to the videos and even guest videos. I'm sure there'll be a lot of questions and comments in the soon. As we wait for them, we will invite Dr. Rajeshri Paladi. She's the secretary of the Kasoga presently, and Madam is joined us now. Could you give us a few words on the occasion of this webinar, Madam? Can we see? I could see her. Not. We also have with us Dr. Suman Gaddi. She's the treasurer of, presently the treasurer of Kasoga. Madam, could you also take the opportunity to talk to the endoscopy committee and all the delegates on today's webinar? Right then. We have the final presentation for the day, and nothing less. It's we invite Dr. Santosh Rathod. He's the young endoscopist from Vijapur, and he's done his MBBS from KIMS Hubli and his master's from PGI Chandigarh, and his senior residency in JIPMA Pondicherry. And he has done his fellowship in minimal access surgery from Mumbai. And his special interests are in endoscopy, dealing with congenital uterine anomalies and also high-risk pregnancies. He's got publications too in the national journals and he has and poster presentations. So we welcome you, Dr. Santosh Rathod. Yeah, his topic is laparoscopic cystectomy, essentials in the pre-op preparation and the safe execution of the surgery. Welcome, and the mic is yours. You're muted or soft. We can't hear you, sir. Dr. Santosh, I don't think I can hear you. Mr. Arun?
Santosh, you are muted, I think. Unmute yourself and start.
Hello, Santosh. Probably mic setting nodko. Just check your mic settings. Otherwise, you log out and log in again.
Am I audible?
Yeah, now you are, yes.
Audible, but
Yeah.
the volume.
ಕೇಳ್ತಾ ಇದೆ Santosh. We can hear you, but it is low. Speak up now.
Sir, am I audible now?
Yes, yes. Speak little louder.
Am I audible, sir, now?
Yeah, you are audible. I think network is weaker, I think. Your lag is there. You continue, Santosh.
Is my slides visible?
Yeah, now you're loud and clear, and your slides are visible, but they are, if you could, on full screen, if you could make them, if
Yeah.
Yeah.
Fine, ma'am.
Done. Go ahead.
At the outset, I would like to thank Endoscopy Committee, Kasoga, Dr. Vidyathabe ma'am, Dr. Ravikant sir, for providing me this opportunity. My topic for today is the laparoscopic essentials in cystectomy, preoperative preparation and safe execution. The topics I'll be covering are the types of masses, when to operate, preoperative checklist, general operative strategy, specific operative strategy for cystectomy, mass extraction in various types of cysts, and cystectomy in pregnancy. The types of cysts, as we know, most of my topics will be covering the benign ovarian cyst, and most common is the functional cyst, followed by endometrioma, serous cystadenoma, mucinous cystadenoma, and mature teratomas. And benign non-ovarian cysts are paratubal, hydrosalpinges, and tubovarian abscesses. As per the diagnosis of these cysts, ultrasonography plays a very important role because it is the first investigation of choice to diagnose these cysts. Then further going ahead, we have the tumor markers CA125 and HE4. We have the risk of malignancy index if we are suspecting any malignancy in these masses. And now the recent one, that is the International Ovarian Tumor Association classification, which lays the B rules for benign tumors and M rules for malignant tumors. And this has made the system of classifying the tumors into benign and malignant more standardized, and it has decreased the inter-observer bias. So whom to operate? As per the RCOG guidelines, in premenopausal woman less than 5 centimeter diameter ovarian cyst, we need not do anything. If the cyst is 5 to 7 centimeter, then yearly follow-up. Larger cysts, then surgical intervention and further imaging. But if there is a persistence or increase in size of these asymptomatic cysts, then this warrants surgical intervention. Or if the cysts become symptomatic with torsion, rupture, acute abdominal symptoms, then that they need surgical intervention. In postmenopausal woman, any cyst, asymptomatic, simple, unilateral, less than 5 centimeter needs a follow-up of every 4 to 6 years with CA125 levels. And if the woman is symptomatic, then further surgery is needed. If at all we are suspecting, if there is a suspicion of malignancy or persistent complex adnexal mass, then further evaluation by using MRI or CT and surgical intervention is needed. So why now laparoscopy has become more preferred modality of treatment is because of the reduction in pain, less use of analgesic, shorter hospital stay and faster recovery, which makes the actual cost of laparoscopy very less, and fewer adhesions post-operatively and less post-op morbidity. So then coming on to the operative preparedness, that is first thing is informed consent. Condition specific consent has to be taken and all the pros and cons of surgery to be discussed with the patient. All available other treatment modalities, including open cystectomy, to be given to the patient. Possibility of oophorectomy in case there is any chances of excessive bleeding or non-separation of the cyst, or if there is the possibility of the risk of malignancy after the histopathology reports, and the possibility of conversion or extensive surgical time should be explained to the patient in detail. Then preoperative bowel preparation. Mechanical bowel preparation is not recommended for routine gynecological procedures. Some people prefer low residual diet for 7 days. According to the recent Enhanced Recovery After Surgery Society guidelines, routine preoperative bowel preparation is strongly discouraged for minimally invasive gynecologic surgeries, and the combination of mechanical and oral antibiotic bowel preparation should be considered only for colon resection, if colon resection is planned. Then what are the instruments which we have to, along with all other routine laparoscopy equipments, the must-have instruments for cystectomy are a plain grasper, which is more commonly used to hold the ovarian tissue. Then a toothed grasper or a needle holder, which gives the sturdy pull, or which is used to separate the ovarian cyst wall. Then a suction cannula with a wide bore. There are suction cannulas which are available with a smaller bores, but if the contents are thicker, then there will be chances of blockage of these suction cannulas, and that will cause delay in the surgery. And a good quality endobag, which is very strong enough to hold the cyst. Then the general operative strategies, that is, as per our first talk today, the first entry should be tailored according to the surgical requirement and the size of the tumor. Then basically what most of the people follow is to take the first trocar entry just 4 finger breadth above the upper margin of the cyst in case of bigger cyst. In case of suspected adhesions, pneumoperitoneum is secured with Viris needle or with open Hassen's technique. And start with the thorough inspection of the cavity. Whenever we are entering inside, thorough inspection of the cavity is a must. Looking for the other ovary and tubes is also very important. Then adhesiolysis, if at all required, adequate adhesiolysis should be done. It gives mobility to the adnexa and it permits complete evaluation of the cyst surface. Then the goals of the surgery are complete resection of the tumor, that is the cyst wall, with minimal harm to the normal ovarian tissue. And then correct dissection in the cleavage plane. This we have to keep in mind. The only way to have a successful cystectomy is go and enter into the cleavage plane. The most important point is how best we get the cleavage plane between the ovarian and the cyst wall decides the best operative procedure we are doing. Then the specific strategies, these are puncture and aspiration, cystectomy, oophorectomy, adnexal torsion, and special consideration in cystectomy. This I will be covering. So puncture and cystectomy, it was performed earlier because of the high recurrence rates of up to 53 to 85%. Nowadays it is not done, very rarely done. It can be considered in cases with large cysts to facilitate manipulation, or after cystectomy, in-bag aspiration helps to reduce the size and it is the extraction of the specimen. This puncture and aspiration is done by means of endoscopic needles or by directly introducing the suction irrigation cannula into the cyst. A small incision in the ovarian surface is made after grasping the anti-mesenteric area. This I will be showing in my videos, and the cannula is directly inserted. Cyst can be directly perforated by means of trocar. So here in this video, you can see that this is a very large cyst. First, I'm inspecting the area. This cyst was approximately about 16 week size, and it was occupying entire pelvis. We cannot see the uterus, cannot see the other wall. So I'm taking a direct entry into the cyst wall. Actually, because while pulling up the cyst from the below surface, there was a puncture, and it was an endometriotic cyst. So I decided to go directly from above, and I have introduced the trocar. From trocar, I have introduced the suction cannula inside. So the suction process is going on. So slowly we can see the visibility of the improvement in the visibility of the pelvic structures. The cyst has the tense consistency of cyst has now reduced. So this was cyst puncture for a very large ovarian cyst. Coming to the most important, that is cystectomy. The objective here is to complete enucleation of the cyst with minimal trauma to the normal ovarian parenchyma. Cyst capsule can be punctured or it can be taken out intact. The basic principle is to respect the cleavage plane because that facilitates the dissection, it reduces the bleeding, and it minimizes the harm to the ovarian tissue. There are many newer, some people try using hydrodissection to get the good cleavage plane. So this is a video of a cystectomy. Here, this was a para-ovarian cyst. Here I am trying to take out the cyst en masse, that is without puncturing the cyst. Because it was a para-ovarian cyst, I have that liberty to push and pull the paracystic structure. So that because if it was ovarian, it would have damaged the ovarian cortex. Now you can see how by traction and counter traction, the cyst is getting separated. Once the cyst is separated, then I am using bipolar coagulation device for cauterizing the smaller vessels. Once the cyst is separated, we can puncture it and take it out through one of the ports. So this here I am showing the cystectomy of a very thin walled cystic structure. Initially, I'm trying to find the cleavage plane. Here I decided to use bipolar cautery because using scissor or anything would have easily damaged and punctured the cyst. But unfortunately, sometimes what happens is the bipolar current also it can easily puncture the cyst because of the intraluminal pressure. Here you can see I'm trying to find the cleavage plane. This differentiation between the cleavage plane and the capsule of the cyst and the ovarian cortex is very important. Once we try to find out this space, then so accidentally it was the cyst wall puncture. So because it was a very thin walled cyst, so very gentle and bit by bit, I am using a plain grasper to hold the ovarian tissue. This is the punch biopsy forceps, and one side I am using the needle holder to get the grip on the ovarian tissue, and because these thin walled cysts are more prone to have the tear in the cyst wall. So I am going very gently, millimeter by millimeter, I am separating it. Because it cannot withstand the pull which we will give with the instrument. So such gentle pulling of the cyst wall will eventually get the cyst into one single. Otherwise, if we pull it too much, then there will be tearing of the cyst, and again we have to go back to the ovarian tissue, and we have to do more digging on the ovarian tissue to take out the cyst wall. So this is a lap ovarian cystectomy for a large ovarian cyst. Here it was a 15 centimeter ovarian cyst. See, on inspection, I am doing the general inspection. Then I have introduced the trocar for to aspirate the fluid. Once I get the entire vision of the pelvis, now I have proceeded for cystectomy. Here, this cyst wall this was a bigger cyst with a thicker cyst wall. So I am using adequate traction and counter traction to separate the cyst wall. You can very well appreciate the bloodless dissection that is happening even when the cyst was so big with so much of vascularity. Then the cyst was it was taken end bag, the glove bag, and taken out through the side port. So this is now coming up to the cystectomy in cases of endometriosis. Recently, because of the increase in the cases of endometriosis, there has been so much of talks or so much of webinars we hear about endometriosis. Here you can see. So adhesiolysis is the first thing. We have to separate the entire ovary. You can see the other ovary is normal, and there is a cyst in the left ovary. During adhesio, I am very meticulously, I am trying to separate the ovary from the ovarian fossa where it is adherent. This so because of the thin wall nature, it got ruptured, and because it was it was not accessible area there below, so I decided to take a nick above and drain the entire cyst. Here you can see how I am trying to pull the ovarian tissue to get the tissue plane between the ovarian cyst and the ovary, between the ovarian capsule and the cyst capsule. Further adhesiolysis I am doing. This was a bicornate uterus with endometriotic cyst. So after adequate adhesiolysis and taking up from the ovarian fossa, so I am catching the cyst wall with a toothed needle holder, and I am catching the ovarian tissue with a non-traumatic instrument. So this basically reduces the tear which happens because of the pull during cystectomy procedures. Here you can see the bloodless blood is there, but very minimal bleeding is there. This is because of the proper cleavage plane which I had taken. Then what is the present controversy that is that is surrounding the cystectomy? That because of cystectomy there will be decrease in the serum AMH levels after cystectomy. So there are various studies. One of the study from JIPMER, it shows that after benign surgeries there is a significant decline in AMH levels in the immediate postoperative period. But once the patient is followed up for 3 to 6 months, the eventually recovery of the AMH was from 65 to up to 65 to 85%. But we have to remember that post endometriotic cystectomy, there is a significant loss of ovarian tissue. This permanent loss of ovarian tissue causes permanent loss of or permanent decrease in the AMH level. So there is this difference we have to understand between cystectomy in a benign ovarian cases and cystectomy in endometriotic cases. So coming up to the next, that is for whom we have to do oophorectomy or adnexectomy. It is reserved for the patients with highly suspicious masses or solid tumors and adnexal tumors in postmenopausal women. Most of us might have come across the postmenopausal woman after hysterectomy. They come with adnexal cysts. So the objective here is complete removal of the ovary while avoiding harm to the surrounding structure. The pedicle hemostasis is achieved with safeguarding the ureter while coagulating the IP ligament. So the technique here is the proper adnexal exposure, adhesiolysis, either by adhesiolysis. Adnexa is exposed either by adhesiolysis in post-hysterectomy patients or by moving the uterus to the other side using a uterine manipulator or any grasper in normal patients. The adnexa is medialized to maintain the tension on the adnexal structure, and to safeguard the ureter, the peritoneum parallel to the IP ligament is cut and a window is created so that the infundibulopelvic ligament is isolated, coagulated, and dissected, and there is no much harm to the ureter. So this was a post-hysterectomy patient, post-hysterectomy who had an ovarian cyst. You can just observe you can just correlate the vertical scar which had the same vertical omental adhesion intraoperatively. After adequate adhesiolysis, so adhesiolysis was the first. This was the adhesion. There was no space for auxiliary ports. So here I am after the adequate adhesiolysis, I am medializing the adnexal structure, and the basic principle remains the same. First go for the round ligament and then create the plane in the broad window in the broad ligament. I am using bipolar shearer for cutting here. Actually, we can simply dissect the peritoneum, skeletonize the infundibular ligament properly, and also take the and also cut. But here I am en masse cutting, coagulating and cutting all the things. Medializing the adnexa is very important because adequate pull during medialization causes less uterine injury, less ureteric injury because of the fall of this IP ligament. So next, coming up to the next topic, that is how do we take out the cyst masses. A smaller cyst, they are extracted directly through the primary port by using a reducer and using a 5 mm scope. Or a larger cyst, it can be divided into, this is all about benign cyst. Larger cyst, it can be divided into two halves and taken out through the umbilical port, or it can be put into an endobag or taken out through the umbilical port. Then the dermoid cyst, the cyst is placed end bag and the bag is closed and it is exteriorized through one of the ancillary port or through the umbilical port, and the cyst is punctured. The liquid component is aspirated slowly, and which is followed by the solid component, that is the tuft of hair or any other solid tooth-like structures. They are taken out by using Ohm forceps or Cocker's forceps. So this video is taken from. This video I have taken from my mentor, Dr. Vivek Salanki sir, from Mumbai. This case was presented to us. The case was done during when I was doing fellowship with sir. Here we had bilateral ovarian masses, which were dermoid cysts, and bilateral twist or bilateral torsion was there, bilateral adnexal torsion. So first principle was to detort. So you can appreciate, I think, the entire ovary is occupied with the cystic structure. We are not able to find the normal ovarian tissue here. But the problem was both the ovaries had similar cystic lesions. So the challenge was to save as much as ovarian parenchyma, ovarian cortex as possible for further fertility of the patient. So once the adnexal torsion was released, then endobag was, then this is the torsion on the other side. So this you can see, once the torsion is released, the endobag is placed inside, and the entire cystectomy procedure was carried out in the in the bag, so that any spillage of the sebaceous material that will not that is taken care of from spillage in the peritoneal cavity, and that will not spread further, and it can be easily aspirated. Here you can see, here you can see how the entire ovary is put in the bag. So if at all the endo bag is not available, we can use the Euro bag, which is regularly available in most of the OTs. We can cut it and cut the upper part and put it inside, because Euro bag is the bag which is having more capacity, so that you can easily manipulate things. Once you put the ovary inside, the bag should not be very small, so that your movements are restricted. So here you can see the dermoid cyst. So N-bag cystectomy really needs patience. So you can see how the cleavage plane is detected, and it is followed for the cystectomy. So there is a notion about the spillage of contents of the dermoid in the peritoneal cavity, which causes chemical peritonitis. But I was going through the literature, and I found out that the incidence is only 0.2%. So, and the one basic thing which we have to remember is use a warm saline, so that the sebaceous material will become more watery, and it is easily sucked while giving a wash during in the dermoid cyst patients. So this was the remaining remaining ovarian tissue. Then it was then again sutured back to its anatomical shape. So this is the final picture of both the ovarian cystectomies. So this is the external picture of after dermoid cystectomy. What we do is, after taking out the endo bag, we spread it outside, and on one side we have a suction to suck the cheesy material, and one side I am holding a womb forceps, and this is the tuft of hair which is removed. So what this causes is this avoids the staining of the entire area, and also the port side. Here you can see the Euro bag which I have used as a endo bag. So next, coming to the topic of adnexal torsion. Torsion is twisting of the adnexal structure around the plane defined by IP ligament and the uterovarian ligament. And the incidence is 2.5 to 7.4% in women with acute abdominal pain. Most commonly, reproductive age group women are most affected. The basic concept here is the voluminous adnexal structure predisposed to torsion. So cystic teratoma and functional cysts are more prone. You can see in teratomas, because of the fatty material, it is more voluminous, and the right side is more on the right side, torsions are more common than the left side, maybe because of the sigmoid colon on the left side. The laparoscopic management is the ideal way, because it is the way where we can establish the diagnosis of torsion and also definitively treat it. Detorsion followed by cystectomy, as I have showed in the previous video, or cystectomy followed by detorsion in larger cystic lesion is preferred. Then coming to the point of oophoropexy, which some people, some of the surgeons will advise to do oophoropexy. The goal is to reduce the recurrence. Here the fixation of the uterovarian ligament by the ovarian extremity is done to the posterior broad ligament. Then coming to the topic of cysts in pregnancy, adnexal marxes are diagnosed in approximately 1 in 600 pregnancies. Majority as functional cysts. mature cystic teratomas, and benign cystadenomas. First trimester, observation is the rule and operate only if symptomatic or show malignant features. Then surgical intervention if there is adnexal torsion, cyst rupture, peritonitis, or if there is hemorrhage. Physiology, the most important thing which we have to keep in mind while posting these cases for surgery is the physiological changes like increased blood volume, cardiac output, and oxygen consumption, and decrease in the functional residual capacity of lungs should be considered. Establishment and maintenance of pneumoperitoneum is of prime importance because fetus is sensitive to maternal CO2 levels, and fetus very early develops acidosis that calls for careful intraoperative monitoring. And then preoperative anesthetic assessment has to be preoperative anesthetic assessment. Your coordination with the anesthetic team is very important for patients where we are doing cystectomy in pregnancy. Then proper procedure related consent and the risk of fetal loss should be explained. Surgery is delayed until second trimester to reduce the risk of both teratogenicity and miscarriage. Police catheter should be placed prior to the surgery because we all know the gravid uterus it pushes the bladder, and the nasogastric tube is inserted to reduce the risk of gastric perforation, because most of the times we choose the upper area to put our primary trocar or for Veres entry. The peritoneal access can be obtained using Veres needle or open laparoscopy. CO2 should remain between 10 to 12. And pre-operative and post-operative fetal monitoring is a must, and it is also reassuring for the patient. Then pneumatic, because pregnancy is a hypercoagulable condition, pneumatic compression devices for both intraoperative and post-operative DVT prophylaxis should be considered. So this is my last slide where I am showing a cyst. This was referred as a large cyst with some hemorrhagic content, but you can see the vascular nature of this cyst. After seeing the vascular nature and after looking at the adhesions while manipulation of the cyst, see, this is the you can very well appreciate the vascularity and the adhesions. So two M points, so 2 points of iota classification of USG. That is, one is the large cyst and another is the vascularity. Here it has proved, and it was actually a malignant teratome. So take-home points are adequate evaluation is a must. Use of proper technique to minimize harm to the normal ovarian tissue should be mastered. The risk versus benefit of cystectomy is to be thought, and the cleavage plane of dissection is the most important point which we have to find out in any of the cystectomy patients. Thank you.
Thank you, Rathod. That was a
Thank you,
wonderful explanation about a complete coverage about a cystectomy. I think
sir.
there are many questions are there in the chat box.
Dr. Santosh, thank you so much. I was sorry I was muted.
Thank you, ma'am.
Yeah, thank you for the exhaustive and detailed discussion. Surely useful to all the delegates, especially those who are starting out and you're there. Dr. Prabha, as chairperson, would you coordinate
Yeah.
the answer session?
Yeah,
Or
really,
have your expert comments? Please call on the other experts on the webinar who could give any comments, please. Yeah. We have had 3 speakers on
Yeah.
3 different
See,
topics, and there are some questions, questions and comments also in the chat box. Dr. Ravikant will also coordinate, I'm sure. Go ahead, Dr. Prabha.
yeah, hello. Yes, ma'am. Dr. Prema, madam, it was really a very excellent talk series. It was very impressive to listen the Dr. Sonia's talk.
Yeah.
And as she really told that all the techniques of port insertion, but most safe post insertion when we go for supra-umbilical is, I feel, it is an open technique. And we being a gynecologist, we always are behind to use this technique, but actually it is a very safest technique to enter into the abdomen. That's by open technique and with using the blunt trocar. And I am using this technique since last 10 years. Before that, I used to use a direct trocar entry, so I felt this is a far safe. And as per she has shown all those recent and fancy technique of trocar entry and those all devices, those looks quite glamorous, but for practical purpose we always use, rather than disposable, the reusable steel tokars. And about Jay Prakash sir, of course, he has done wonderful justice to his talk. He has not only demonstrated, but he has shared his all experience about the myomectomy. And it's, of course, as per his suggestion, actually a proper mapping of myoma before going for myomectomy is very important thing, so that we will not miss any myoma also. And we can see, always great surgeons tell that for any surgery first happens in mind, and then we will go and apply over the operation table. So it is true with myomectomy, especially when it is multiple myoma. You have to plan your surgery prior, and you have to do it once in your mind and then start. And we have to tailor-made our incisions according to the location of the fibroids, your skills, and your available what do you say, equipments. So he has really told that's all about the myomectomy. And what I noticed in Dr. Santosh, your talk was really very, very elaborative. Only few points I want to add is, in case of dermoids, as you said, we have to prevent the spillage, but in case the spillage happens, don't worry. I have a case of 27-week size dermoid where nulliparous girl, unmarried, even in such a large, huge dermoid where you are tending to save the ovary, the spillage is going to happen. You cannot prevent such huge dermoid spillage, but really, as if you use a hot normal saline and wash it, it will take, of course, longer time to clear all those floating materials, but nothing to worry. Give good antibiotic coverage, that will not, it will take care of that spillage. And for there is actually one more method of laparoscopic three what do you say, three grasper technique for the medium and large size thin cysts, to enucleate the cyst wall. If you are using third port, then it is better to hold the ovary by two ports and then enucleate with the third grasper. That will really help you, Dr. Santosh. Means I was just telling, if you are using only two ports, then it's okay. In case of huge fiber, so that we should not have to struggle for a longer time. And then as you say, sometimes it is really helpful to use a diluted vasopressin in cases of dermoid and endometrioma when you are excising the cyst wall. There the damage to the other normal ovarian tissue is less, and your dermoid really comes out so well when you inject a diluted vasopressin into the ovary. So these are few points which I wanted to share, and really everybody has done their best, and yours was so awesome talk. Thank you. Thank you for giving me this opportunity to share all those talks.
Dr. Ravi, there are a few questions in the chat box. If you could
Yeah.
voice them out, though there are some replies, but for everybody, if it for good discussion, it will make. There are some for Dr. Sonia on entries.
Questions, madam.
Can anybody read the question, because I have this thing on the mobile.
Yeah, there is one question is there to Dr. Jaiprakash Patil. Role of USG in detection of abdominal wall adhesions.
Yes, sir. Yes. See, basically what the person wants to ask is a ventrofixed uterus, no?
Yes.
Yes.
Yeah. Might be.
See, ventrofixed uterus, unfortunately, is underdiagnosed entity. Okay. Whenever a patient, previous 1 LSCS, 2 LSCS, comes with a chronic pelvic pain, and on ultrasound, you feel nothing is there. Everything looks normal. But two things. One is the elongated cervix. Okay. That should raise the suspicion. And it is always retroverted. So these two signs. And if you look into, a trained sonologist can diagnose a ventrofixed uterus. It can be diagnosed. You may get confused if patient is very obese and you can't make out. But most of the times, more than as a common thing, we can diagnose a ventrofixed uterus by ultrasound, transvaginal ultrasound, not transabdominal.
Even clinically also cervix will be
Yeah,
pulled away.
Yes.
So pulling the cervix will lead to pull up the abdominal wall.
No,
Also,
that may be very painful. But as you said, parvaginally, it will be pulled up.
Yeah. That's called a shade sign actually.
Yeah.
So long back before ultrasonography has advanced, this sign they used to look for the ventrofixed uteruses.
one more question is there for Dr. Sonia.
Hello.
How do you proceed lap entry in patients with the previous hernia repair with mesh?
Sir, actually, most of the cases like that, we have to go with the Palmer's point, because guidelines also says that Palmer's point is the point where in most of the cases you will not find any additions. So this is the safest point, I feel.
And one more point is Jain point, where there also will get a very less additions, which is
Also, Von Young's point is also helpful sometimes if they are having a lower abdominal wall hernia. Hello.
Yeah, continue.
Yeah. Sir, Von Young point is also used for these kind of cases.
Dr. Prabha,
Which
can you
is in
explain what are
between
the
the
three
umbilicus
points? The
and the
Palmer point, the Jane point,
Yeah,
and the Von Young point. How do they differ? Can you explain it to the audience?
see, it is a citisternum in
There is
between
some
the
disturbance.
Hello, somebody's somebody is talking. If
Okay,
you
Dr. Prabha.
take umbilicus it is a midpoint of the umbilicus, and the in between that, if you take a midpoint, that's a Von Young point, but better to take open technique and then put the code there. Hello.
Yes. There is one more question is there. Is it possible to map the mesh by imaging methods?
Yes,
Very
it is possible. It is possible. You need to take a linear probe.
Okay.
You need to take a linear probe, and you need to be trained to look through the mesh. It is possible. Okay. Just want to answer whether we can go through the mesh. The answer is yes. If you have made a primary trocar entry somewhere safe, you can go through the accessory ports through the mesh. Nothing will happen. So it is, you don't have to try and avoid the whole. Sometimes there are patients with total abdominoplasty. Sometimes patients who have underwent ventral hernia repair with a 15 centimeter, 20 centimeter mesh. You can, accessory ports you can go through the mesh. Nothing will happen.
Okay. There is one question.
Sir, entering on the accessory port using a 5 mm trocar and making the 10 mm entry is also can be done. There we can directly enter through the mesh.
No, exactly. But if you are scared to enter the primary trocar because of the adhesions, because whenever you put a mesh, there is a chance of adhesion. Okay, if
Yes.
ball adhesions have to be ruled out. So either you go to modified Palmer's or a Jane point or other point where if you have made an entry and after that, if you are sure that no adhesions, you can go through the mesh. That's what I was trying to tell. I agree with you. Even the primary
See, but-
trocar, you can go through.
But see, I little bit differ. 10 mm trocar is, it really may, see, we will see sometimes 10 mm port site hernias. When already repaired hernia, why to take the...
No, ma'am. No, ma'am. 10 mm trocar entry after, see, you should remember how the hernia heals. Once you put a hernia, it is like putting another abdominal, rectus muscle.
Dr. Prabha, you
Fibrosis.
are muted.
So
Dr.
you
Prabha,
can, so that small rent which you have made does not cause hernia again. So you don't have to worry about it.
Yes, there's one question to Santosh. Sometimes if the ovarian mass is, you are not finding the proper plane. So what is the better? How will you deal with that patient?
So in such cases, going ahead with cystectomy first, and then slowly dissecting the, slowly tearing up of the wall. As I showed in one of my videos, we can slowly tear with a grasper, with two graspers. We can tear a little bit because the elasticity of the ovarian tissue and the cystic wall is different. So both of them tear at a different level, and that will show you up with the cyst wall. And there we can use a toothed grasper or a needle holder to grasp that inner cyst wall and peel it off.
And hold the cyst wall very close to the site of demarcation.
And always, whenever we are doing cystectomy, we should not pull too far. That one hand, in one grasper, we are holding the ovary, and the other grasper, we are holding the cyst wall. And because it is coming, we should not keep on pulling it. Our both hands should be very much close as and when we move as with the cystectomy part. That avoids the unintended tearing up of the cyst wall.
Thank you.
So that's in the continued question in the, what is the experience about keeping a congested ovarian mass after the detorsion and plicating round ligament?
So
The ovarian function, how do you decide upon the vitality of the congested and dotted adnexa?
The overall consensus is to not do oophorectomy even if there is a lot of congestion, because even the pathology of the torsion is the torsion has happened followed by congestion, and once you detort, the edematous tissue of the ovary will slowly resolve. With that resolution, whatever the ovarian tissue is there, that will gain its function. It has been seen that the ovarian function has been gained in most of the cases. So not to go for oophorectomy, and I was looking up for the literature, and they have made a study where there is a comparison of cystectomy patients between a surgeon and a gynecologist, because gynecologists are more favorable for ovarian conservation. So all these congested masses, they are more conserved by gynecologists. So any type of congestion, any bigger ovary, just detort it, take out the cyst, and if you are feeling it is very lax and it will go for T-torsion, again it will go for recurrent torsion, then you can go for application, then you can go for attachment of the ovary to the posterior uterine wall.
See, can I add? Hello.
Yes,
Go
ma'am.
ahead, Dr. Prabha.
Yeah, see, actually, post detorsion, especially in case of young girls, we see many young girls when they go into the stage of puberty, that ovarian normal ovaries also get torsion, and they usually land up with the pediatric surgeons. And in such cases, if you find that normal ovary has got tossed and the other side ovary is also bulky, better to fix the
Both.
contralateral ovary also, which has not retorted, for prophylaxis purpose, because we have seen few cases where somewhere it has been done for torsion ovary, oophorectomy has been done, and with one ovary, the patient comes in 1 or 2 years with again torsion of the other ovaries. So if you really feel that the other ovary is bulky and elongated, this thing, better to do the ovariopexy. Even hot dog in cross bun technique and all that has become very famous as it's an interesting name, and we usually use that. And one more thing is, I follow when I really very blackened out and ischemic ovary I preserve, I usually follow with them with a Doppler after 1 month and all. If you, and the size also reduces and the flow also increases and all, so they are really comfortable. And if you are really doubt, you can opt, you can counseling for relook laparoscopy, and that is more what do you say, cost versus benefit. So that is more beneficial rather than knocking out the ovary. You can counsel if our symptoms doesn't persist. We may go for second look laparoscopy, that we have to counsel the patient. So
There is
that
no
yeah.
there actually is no comparison between the cost and the benefit of saving a ovary. I
Yeah.
feel.
No. For cost of second look laparoscopy is, sometimes patients will worry about their, one more surgery or what. So we have to counsel them that we have to, even though it is a little costlier affair you are feeling, but we are keeping it back so that it will be more beneficial for your sake. Because sometimes the patient go to 2-3 doctors and then come to you, and they have told that she needs the ovary to be knocked out, and you tell that I will keep the ovaries. And sometimes that symptoms doesn't persist, the symptoms doesn't get relieved, or the size will increase or something. We don't know some masses. So better to counsel them that thing may need, and then go ahead with the surgery for better, safer size. That's a practical point I am telling you.
Yes, the right point is mentioned. And especially the pain abdomen may persist sometimes.
Yeah.
Yeah.
So this thing has happened out of experience. I'm telling, because this has happened with me. I have to go to second time laparoscopy and then take out that ovary, because that pain was persisting and that size was increased. And anyhow, she was little nearing 40 years. That doesn't matter. But, we have to give them chance. That's why we will give sometimes. But better to keep a word and then go. But when we follow with the Doppler studies, after 1 to 2 months, means after 1 month, I start doing Doppler. If the vascularity comes out and the ovary size regresses and looks normal, then nothing to worry. Automatically, the patient will not have symptom also. But we should keep that thing that prophylactic oropexy has got definitely role.
Yeah, especially in young girls, as you mentioned.
Especially in young adults.
Yes, madam.
There's another question about, sir.
Yes, madam.
There's an interesting question from Dr. Kalpana Tiwari. She's put in a lot of questions. Her question is on role of ultrasound in detecting intestinal adhesion. A lot of us want to know the answer to the anterior abdominal wall for deciding on the primary port. Dr. Sonia and Dr. Jay Santosh.
Actually, now it's a new technique of periumbilical incision of saline infusion to know the this thing, intestinal adhesions, and then proceed.
When would you do it? Like at what level? Like someday out of the OT, that is.
Means that has to be. Then you have to have a portable USG there and there itself, and then you have to proceed, because this is periumbilical saline infusion. That is, I have already mentioned in my slides also. It's a new technique in which they instill the saline at the site, and then after infusion of the saline, they see the movement of the saline, and through that only they detect the intestinal adhesion.
Doing that? I mean, among the people on the board webinar today, anybody is doing that method? Find out intestinal adhesions before they enter.
If we are suspecting more adhesions, then open technique will be the best of all.
Yeah, I also support
But
better
in
to go open
open
technique.
technique,
These all things will not get, you will not get into any trouble if you go into open technique. And use a
but
blunt
ma'am,
trocar. Use a
uh-huh.
blunt trocar, you know.
But ma'am, in the
All
guidelines
cases,
also,
no need to,
Is very
you consider all cases as a complicated only and go, no, why to, into go into the hassle. If you are finding lot many, only you might have to change your port side. All the cases, you should not enter into the umbilical port. It's not necessarily you should enter into the umbilical port. If there are multiple, hello,
Yeah,
Yeah.
continue.
Yes.
yes, ma'am.
yeah, if there are multiple scarred abdomen, better, as you said, you go either a Palmer's point or Myomectomy point. Why you have to go and enter into the umbilicus only, right?
And that's
And
always better
use
that
the
we do
open
have the
technique.
accessory one. And open
Hello.
technique, ma'am, in the guidelines also they have mentioned that Hassan's technique has more incidence of bowel perforation as compared to other techniques, but it depends on the surgeon's experience. If you go to the umbilicus and you know the adhesions are there, take the other side open technique and you can always win the situation.
Yeah, better to go supraumbilical. Nowadays, most of the gynecologists are going into supraumbilical only. Nobody
Supraumbilical.
don't go into the umbilicus port and then use the blunt trocar. That's why I told we gynecologists are resisting to go by open technique, which is a more safest way to enter into abdomen.
One question, Dr. Jaiprakash Patil. When do you go for uterine artery ligation for myomectomy patients?
Yeah. Actually, I had edited another video to show bilateral temporary uterine artery ligation, what Dr. Sanket Pisat has explained. I do it when, especially there are very large fibroids, multiple fibroids, and if they are especially indenting onto the lateral myometrial wall. So such cases, I do temporary uterine artery ligation by what is called as a shoelace technique. But small ones, only solitary 1, 2, 3, usually I don't. But large ones, especially under the lateral myometrial wall, I do. I had edited, but time was not permitting, so I just deleted it. Yeah.
And one more question is mapping. What is the success rate you find it intraoperatively same findings?
Oh, my colleague Raju's strike rate is amazing, more than 90%. So I can't generalize it, but then my hospital, my colleague Raju's strike rate is more than 90%.
So what about the use of interseed post myomectomy? What do you think?
Yeah, interseed. Actually, I do have interseed, and then I do apply interseed, especially if there are a lot of incisions I have taken on posterior. And actually, most deciding factor for putting interseed is affordability. I am practicing in a kind of semi-rural setup. Spending another 5,000, 6,000 rupees only for interseed probably is sometimes difficult. But I prefer to put interseed in posterior myometrial incision because that is where the adhesions are more common. But it is great to use if we can use it. I do use once in a while, not too frequently.
And what is the routine post-operative follow-up for myomectomy patients? Like
now we do get routine ultrasound done after 2 months. Okay, to look for any hematoma, any scar. Usually, you would see Raju shows me about the still yet to be absorbed V-locks, hyperechoic, this thing, suture lines he will show me. But what is alarming sign would be to look for, to see a hematoma. That does tell you about the improper healing. That is the only thing I want to see. After 2 months, a routine scan. If everything is fine, usually you can ask the patient to conceive after 3 to 6 months. I don't want to wait more than that.
what is the role of using oral contraceptives to continue?
No, I don't use.
To stop the menses and
No.
isolate the healing. No.
No. I don't use. I don't know, but I don't use.
One
When
question
can
to
when can the patient conceive, sir, after myomectomy?
No, that's what. if it is we go 3, 4, 5 after 3 months, no problem, because healing would have happened. And imagine after 3 months, even if she conceives, the uterus would start stretching and enlarging only after another 3 months. That is another after 12 weeks. So you have
Right.
actually given 6 months for the wound to heal. That is, I think, more than enough. So typically, you can ask the patient to conceive after 3 months.
then itself, is it an indication for abdominal delivery following myomectomy?
Of course.
Okay, so like one question to Santosh.
Yes.
Most important point in a laparoscopic cystectomy is to make sure that patient is not a malignant condition. So most important, is it not? It should be benign. Like what are the most frequently sought after investigations? Like how do you decide that? Less likely it is malignancy.
Sir, that's why I had discussed
About
in one of the slides that most common investigation is the ultrasound, and now the IOTA has a classification. It has devised such a nice guidelines where they classify everything into benign and malignant B and M signs. So once we start to start practicing on these, we will go on having an idea about which are the cysts which are malignant. And apart from that, we have RMI index, that is risk of malignancy index, which uses the CA-125 and menopausal status of the woman and the size of the cyst. So all these, if it is more than 200, then the probability of the cyst being malignant is more. Another is the Roma index, which is less used because it uses two of the tumor markers. And so based on all these things, these are all algorithms where just like in a dual marker or triple marker, we put the enzymes and the computer calculates the risk. So here also, once we put the values of these tumor markers, and the age of the patient, size of the cyst, everything, the tumor calculates the risk and it tells us the probability that the cyst is malignant. So once it is there, once we enter inside, and laparoscopy gives us that advantage over the open technique that that if it is malignant, it can be anytime converted to open surgery. And these are the days when even the most of the complicated malignant surgeries are also done laparoscopically. So picking up the signs earlier on ultrasound, relying on the tumor markers, and the third is once you enter, relying on the vision, on the visual clues from the tumor, gives us adequate idea about the cyst being malignant. In such cases, we have to go we have to better is direct oophorectomy. If you are more sure that it is a malignant condition, then better to go for oophorectomy and end bag, you have to take out the cyst without spillage.
Thank you. Thank you.
Yeah.
And even
If you're thinking
I
biopsy,
think
malignant,
it is already 9 o'clock.
with malignant, you have to do frozen section and
Yeah, frozen section
I
we
would
have.
should be done if you are thinking malignant
So-
pre-op, unless it's on the table.
RCOG clearly mentions whenever you are dealing with a cysts or a cyst where you think the chances of malignancy is more, it is always better to involve a gynec oncologist and always
Yes.
better to have take up surgery for such patients in a center with where frozen section is available.
even if the frozen section is not available, even ultrasound guided biopsy or laparoscopy guided biopsy can also give us a very good clue, like whether it is this thing or not. Because if it is anyways malignant and you feel that it is not operable or this thing, you can go inside. Diagnostic laparoscopy followed by staging can also be done along with the biopsy.
Yeah, that can be
Now
done.
we can take a biopsy and rupture. It changes the stage.
Ma'am, in this thing, first you go for the mapping techniques like USG and imaging techniques, proper imaging techniques. And if you feel like it is more than 200, then definitely they are not. They are also
Then
not
it's
going to
straight
have it.
into staging laparotomy.
Staging
Straight up.
laparoscopy
Yeah.
actually, and then we can see it. And if you feel
think
like
they
it is
frown on
malignant,
that laparoscopy.
See,
Yeah.
one thing I just want to put one thing. Sometimes we have to think out of the pelvis also, and we should keep the thing about Krukenberg tumor. Last week it has happened so. We have actually bilateral ovarian cyst. That was a young woman, 36 years old, and she was having a bilateral ovarian cyst. And she was no other any symptoms of GI tract and all. When we have put the scope, it was something looking odd, and there was already peritoneal deposits, but the ori were not so malignant. And then when we are looked out up over the stomach, and I found that stomach is something that fibrous like kind of thing, and then the called the surgeon in OT and then shown him some of the uterus. He said that it is a linotyplasty kind of thing. She might have a CA stomach and it has a Krukenberg tumor. Then next day we have posted her for gastroscopy. Sometimes if patient doesn't have symptoms, when you have a bilateral ovarian cyst, we have to keep that thing also in our mind. Look outside the pelvis, for the cause of that cyst. And there is no role of doing cystectomy in case of Krukenberg tumors. She will directly go for, chemotherapy. So we should always should not keep only some things in our mind. We have to look out of the pelvis also for the cause.
that is why MRI abdomen pelvis is a must whenever we get
No,
anything.
MRI will not pick you. CT scan also will not pick your stomach CS. You will not advise, stomach see that only endoscopy will pick up the CS.
But some growth we can keep thing it off. No, okay, stomach inside the stomach you're talking about,
Stomach.
which has not even grown outside.
Dr. Ravi,
Yes, madam.
9 o'clock. Do we
Yeah,
end?
yeah.
Do we-
Oh, we can conclude, madam, now.
Okay. That was a fantastic discussion led by the chairperson and the speakers. A lot of doubts were cleared. And so let me formally give the vote of thanks. I start with thanking the speakers, Dr. Sonia, Dr. JP, and Dr. Santosh. Thanks for your brilliant presentations and the discussion that followed. It was very useful, and we wish you best for the thing. I thank the chairperson, Dr. Prabha Desai. Busy as usual, but you bring so much to the table that you just jump in, you're right there, you're practical.
I don't want to miss all everybody's talks. I came without changing.
Yeah, so that's really
Thank
good.
you.
Thank you. And to our well-wishers, Dr. Vidya Tobi, Dr. Bharati Rajshekar, Dr. Rajeshri, Dr. Suman Gadi, who could join us. And in absentia, Dr. Hiramat, Dr. Ramesh, and Dr. Vidya Bhatt. We thank them as usual for your endless guidance. I thank the most wonderful Dr. Ravikant, our chairperson, who organizes these webinars that are so useful, and we always have till the end a lot of delegates. And to the delegates, thank you so much for joining us. You encourage us to have more of these webinars, and so all of us learn in the process together. I thank Mr. Arun for our hosting us and staying with us throughout. I don't know how he does it. So I think I've thanked everybody. And
Thank you.
I'm Dikuna from Mangalore. Thanking and good night. Goodbye.
Thank you, madam. Thank you.
Thank
Keep
you,
it
madam.
Thank you, everyone.
Thanks.
Thank you, sir.
Thank you for the opportunity, sir.
Thank
Thank you,
you.
madam.
Thank you.
No meeting, no, Dr. Ravikant?
Yes, madam.
No meeting. Reminder. Yeah. Okay. So we can thank. We'll complete.
Yes, madam. Yes, madam. Thank you, madam. Thank
Yes,
you.
ma'am. Thank
Keeping it
you.
lively.
Good night, everyone.
Good today. Well kept in timings. Yeah, with including a lot of discussion. It was a good session
Yeah,
as
yeah.
you. Yeah,
Thank you,
okay.
madam. Thank you.
Thank
so
you.
much.
Thank you.
Yeah, bye.
Thank you, Sonia. Thank you.
Thank
Dr.
you,
Prema.
Arun.
Thank you, sir.
Prakash sir, that Rajesh Bhakta sir also has joined. Thank you, sir.
Yeah, Dr. Rajesh. Oh, yeah. I forgot that. Thank you.
Hi.
Hello, sir.
Hi, Dr. Rajesh. Thank you.